Good day. I am Elizabeth Paterno, and I have been tasked by PASCOM to present a proposal for a community medicine curriculum that will hopefully assist medical schools comply with both the Universal Healthcare Law and the 10 program outcomes of the CHED. I am presenting the following curriculum on behalf of the group that formulated it. Aside from myself, the group is composed of Ramon Pedro Paterno, Lorica Opinatan, and Lynn Redoble. Dr. Paterno and I are retired community medicine professors at the UP College of Medicine. Dr. Opinatan is a current professor of family and community medicine also at UP, while Dr. Redoble is a current professor of community medicine at the Davao Medical School Foundation. All of us are graduates or candidate graduates of a public health course. Let me start my presentation with PASCOM's definition of community medicine. This definition is based on the International Conference on Community Medicine that was convened by the Rockefeller Foundation in Bellagio, Italy in 1978. According to the conference proceedings entitled The Future of Academic Community Medicine, the delegates agreed to reaffirm the 1968 definition of community medicine as follows. It is that branch of medicine that is concerned with the health conditions and needs of population groups, and in dealing with these by using appropriate methods and intervention. In addition, we in PASCOM equate community medicine with the realization of the principles and aspirations of primary health care as it was defined in Alma Ata in 1978 and reaffirmed in Astana in 2018. As such, for PASCOM, community medicine is the combination of public health, population health, and primary care. Before I go any further, let me define some more terms so that we all stand on the same level of understanding. Winslow's 1915 definition of public health is still the most popularly used definition of public health, though mostly in an abbreviated form, as I will explain later. Winslow said that public health is the art of preventing disease, prolonging life, and promoting physical health and efficiency through organized community efforts for the sanitation of the environment, the control of community infections, the education of the individual in the principles of personal hygiene, the organization of medical and nursing service for the early diagnosis and preventive treatment of disease, and the development of the social machinery, which will ensure to every individual in the community a standard of living adequate for the maintenance of health, organizing these benefits in such a fashion as to enable every citizen to realize his birthright of health and longevity. Modern day public health practice, however, has dropped the latter part of the definition according to a group of public health practitioners in the United States represented by David Kindig. Note that this part says that public health should be concerned with the socioeconomic determinants of health so that individuals are assured of a living standard that is required to maintain good health. This is the reason why this group of public health practitioners started a movement for population health to augment what public health has been doing in recent decades. Population health studies the health outcomes of a group of individuals, including the distribution of such outcomes within the group. In addition to health outcomes, population health also studies the patterns of health determinants and the policies and interventions that link these two. Thus, population health looks into the reasons beyond strictly health factors why some populations are healthier than others and formulates interventions, including policies, to address these reasons. Let me now go into the clarification and differentiation between primary health care and primary care. Both the WHO and our own Department of Health realize that there is confusion between these two terms, especially among health professionals and health providers. Primary health care is an approach to achieving health for all based on the following principles. First, that health is a basic human right, and that health is not merely the absence of disease, but a state of complete physical, mental, and social well-being. That second, that governments have the primary responsibility for the health of its people. Third, that socioeconomic development is the key to the attainment of health for all, implying that socioeconomic determinants of health should be addressed, which then implies the need for collaboration among the different sectors of society. Fourth, that people have the right and duty to participate in their own health care. And fifth, that teamwork among different professions providing health care and health-related care to the same population or individuals is important to achieve the best health outcomes for our patients and communities. This is interprofessional collaboration. This slide is from the DOH. I just wanted to show this to emphasize that while primary health care is not the same as primary care is an essential part of primary health care. Primary care is the first level of care in the health system. Having thus defined the important terms that are fundamental to the curriculum, let me now proceed to the curriculum itself. The first 3 years of the course progress from the understanding of public health, population health, and primary health care in the first year to analyzing and critiquing existing health problems, programs, and policies, including the Philippine Universal Healthcare Law in the second year, to the formulation of a proposed intervention based on these principles to address the health or lack of health of an individual, family, community, the nation, and the global community. The fourth year is divided into 2 rotations. The first rotation is recommended to last for 8 weeks. The first 6 weeks of which will be devoted to community immersion. In the next 2 weeks, the students will observe the operations of a DOH regional office where they will learn the organizational structure at that level, as well as the different programs that the DOH implements. The second rotation will run for 16 weeks. Here, the students will be immersed in a primary care center run by an LGU, where they will have the experience to conduct primary care clinics. They will also have the opportunity there to observe at the very least, or experience at most, the duties and responsibilities of a municipal health officer. That was an overview of the course. Let me now go into a little more detail per year level. Community Medicine 1 integrates the principles of primary health care, public health, and population health. It introduces the students to primary health care, its definition, the principles upon which it is based, and the context that led to its development and continuing relevance. The first year also familiarizes the students with the definitions and scope of population and public health, as well as the skills required to practice the discipline. The students are likewise introduced to the Philippine health system and the universal healthcare law. A community immersion for a week or 2 is recommended at the end of the first year, where the students will have the opportunity to observe the realities behind the principles learned during the year as they are exposed to the actual situation that a primary healthcare physician faces in a community. At the end of the year, the students are expected to confidently discuss the concepts of primary care, public health, and population health. These are the proposed topics for the first semester of the first year: the Philippine and global health situations, a brief overview of the history of medicine and medical education, the primary healthcare approach, the Philippine health system, and the universal healthcare law and other health laws and policies in the country. In the latter half of the semester, the students will be introduced to population and public health definitions, demography, epidemiology and biostatistics, health policy, nutrition, sanitation, and safe water, family health care, public health promotion and community health education, disaster risk reduction and response, community organizing principles, occupational health, and environmental health. All these topics will be discussed at the introductory level. The second semester will focus on the knowledge and skills required in the practice of population and public health. And the topics are as follows: community engagement, gender and culture sensitivity, communication skills, facilitation skills, health promotion and community health education skills, advocacy skills, collaborative practice, health policy formulation, health budgeting in a government primary care facility, sanitation, and safe water inspection. Finally, they will be introduced to community health program management. The second year will highlight the important roles and contributions of a primary healthcare physician in community health and development. These roles include being a primary care provider, a health system administrator, and a public health practitioner. The students are expected to utilize the knowledge and skills gained in the first year to analyze real-world scenarios in the local settings. As in the first year, a week or two of community immersion is recommended at the end of the second year. Here, they will be given the opportunity to acquire insights on the social determinants of health in a community, as well as to appreciate the important roles and responsibilities of a primary care physician. The proposed topics for the first semester of the second year are the following: health and development, provisions of the Universal Healthcare Law, primary care practice, including person-centered collaborative practice and people-centered primary care, the health system and the devolution of the Philippine health system, management of the health sector, effective community engagement, as well as common community health issues. In the second semester, the course will focus on health systems analysis using primary health care as a lens. Thus, students will be taught about how situational analysis are done. They will learn about the health system's building blocks and how to measure health systems performance. They will likewise learn about the interventions that are presently utilized in our health system to address emerging problems. At the end of the semester, students will be made to analyze a community as a case study through actual interaction with the people. On the third year, students will be given the opportunity to practice two of the most basic skills that the health manager needs to possess: conducting community-based research and creating a management plan for a health program that will address a selected health problem. While going through these learning activities, the students will be able to utilize the knowledge and skills learned in the first 2 years of the course. During the third year, the students will be in the community more than in the classroom, as they are guided to do a situational analysis of a given municipality to select a priority problem. After selecting a priority problem, the students will be required to draft a proposal for a community-based research to find out the social determinants of the prioritized problem in the community. By the end of the semester, the students are expected to be able to submit this proposal to an ethics review board and hopefully get approval during the semestral break, so that by the beginning of the second semester, the students will be able to implement the research, analyze the data, and report it to the school and the community. Towards the end of the second semester, the students will be guided to create and present a program management plan with the participation of the concerned stakeholders. As earlier explained, the fourth year community medicine course is divided into two. ComMed 4A requires the students to practice as a healthcare provider in a government primary care facility for 16 weeks. This rotation requires close collaboration and coordination with the different clinical departments for case requirements and supervision, whether virtual or physical. or face-to-face. While in this facility, the students will also learn the duties and responsibilities of a municipal health officer through shadowing or accompanying the health officer in the performance of his or her various duties. While performing their duties in the LGU primary care facility, the students are expected to deepen their understanding on the building blocks of the health system and interprofessional collaboration while honing their skills in conducting primary care diagnosis and management of the various patients they encounter in the center. For the second part of the fourth year, community rotation, while immersed in a community for 6 weeks, the students are expected to experience and deepen their understanding of the provision of healthcare at the barangay level, the realities of the operational processes in a barangay health station, community diagnosis, collaborative management of a community health program, and advocating for health within the barangay. The remaining 2 weeks of the fourth year rotation, the students will be made to evaluate national health programs while observing a DOH regional center. This proposal requires a minimum time allotment of 36 hours per semester in the first 2 years, 72 hours per semester in the third year, and 24 weeks during clerkship. Community immersion for 1 to 2 weeks at the end of the first 2 years is recommended. A partner LGU for each medical school is also a necessity. So, with this, I believe I have completed my task. Thank you very much.